I haven't read all the credentials, but we do all day, so I'm not going to read all of them. But trust me when I say like he's brilliant, he's wonderful. But what I really want people to understand is that Christian is like the epitome of charm and grace and brilliance, kind of like all rolled up into one. And you just don't really get the opportunity to see him in the venues and opportunities like I do. And so I cannot tell you how incredibly excited I am to have your warm presence, your brilliance, and true charm. I mean, you have like a real old world charm about you. And so thank you so much for joining us today with KRAS Kickers and just talking about biomarkers.
Thank you, Terri. It's a pleasure, it's an honor actually, and a privilege to be speaking with patients, what we are doing in the clinic, but this time also arriving to several other people is really a great opportunity, and thank you for this. And congratulations for the great job that you and the KRAS Kickers are doing, because I think it's one of the pillars of having this kind of achievement that we have is to have the voice of the patients in the first place. And we was together doing fantastic things, arriving from the discovery of these biomarkers to the drug that are actually approved already. So it's really a tremendous efforts, and not only from the science, patients, and also organizations like FDA as well, that they were approving this kind of drugs very quickly. So we can start maybe telling what is a biomarker, no? In a quick words, we say that it's a measurable biological factor. What means that? Could be whatever of the different alterations that we are looking from a gene, for example, from a mutation. Important that we need to understand that in generally, when we are talking about cancer, the mutations are not the ones that we are inherited from our parents and given to our sons, for example. That is a part of things that could be a predisposition of cancer, and that's are the germline mutations. But the somatic mutations, like the case of KRAS, are the ones that we are looking for, provide information about this cancer specifically, different cancers. And that include some characteristics of what this cancer is behaving, how this cancer is more aggressive or not, how we can treat this cancer, and how we can also start to see some mechanisms involved in the resistance and searching for that and treat the patients properly. So I put some slides, and maybe that will help us to understand, and we can go, and please stop me with any of the questions that you have. Let me see if you can see my screen, and I will.
Yes, I can, and I'm just
Yeah.
going to you up front. If you see me wiggling around, it means I probably have a question, and want to get some clarification. But I appreciate your being like tolerant with it, because it's like if we start going a direction, I just really want to get clarity.
No, absolutely. So the idea I put here, always we put our disclosures, what we are working in different projects. But I think we can define here which kind of biomarkers we are searching for, which kind of information is very useful for us. And that's our questions that the patients are doing. What kind of cancer do I have? So this is a biomarker that is involved in the diagnosis of the cancer. What kind of outlook, what is the expected outlook of my cancer? And that is the prognostic factor. We know, for example, that KRAS could be a negative prognostic factor because it's a little bit more aggressive in some cases, but it's also related how I respond to the treatment. So we can have, for example, the predictive part of the biomarker. How is my treatment working? This is the therapeutic biomarker, and we will put some examples of everything that I say. We are also having some safety biomarkers that is new, and some liquid biopsy, for example, the blood draw. We have some information, preliminary information, that we can distinguish some safety, so how we explain the side effects of the treatment. And then when we have a long-term monitoring, that is an important one, which kind of cancer, or how is my cancer relapsing, how I can treat. And there we go for mechanisms of resistance and so on. This is a journey of a patient, and how we can start from the early the advanced. And we was really starting with this research of the biomarker from the part of the final part of the graphic, so advanced disease. There we discover some, specifically in lung cancer, we discovered there are different biomarkers that they were related with drugs that we can give to the patients. And I remember one of the first one that we identified was KRAS, but was one of the last that we target actually with medication. One of these examples is also EGFR. That is a very unique example for a success history, to have a wedding between the biomarker and the drug, and make this wedding work, or this marriage work. And we have several patients that they were passing from different generations of these drugs, and we have first generation, second generation. What means these generations in the drugs means the evolution of these drugs to cover in a proper way different biomarkers, or a same biomarker covering also some of the resistance possibilities that we have in this biomarker. And then we move to this. You see that there are waves. These waves means when the patient is responding and when the patient is progressing. We are also interested to identify these mechanism of resistance that we find there. And for this reason, it's very important that we are testing always, not only at the beginning of the disease, especially when we find a patient who have a drug-able target, that we also continue to have this biology or understanding this biology at the moment of the progression, to see if there is any mechanism that we can continue to target with new drugs or with new way to go and continue to have a good response. In this journey, if we are moving to the center in the figure, we will have there MRD, and that is an area that we are also searching for biomarkers. This means after the surgery, before the surgery, and this area that we call perioperatory, in patients who have, for example, early disease, we want to not only take the cancer out, we want to continue to see how this patient, in the case that is relapsing, how I can identify biomarkers as well there. And now we are very in the way to see these biomarkers, specifically some mutations that have already approved by FDA, different drugs for adjuvant. So after the surgery is done, we give a medication to try to reduce the risk of these diseases coming back. And in the other part of this wave, you see that there are variations that occur during the early evolution. This is before the surgery. We are looking in patients that we are giving some treatment before the surgery, that we call neoadjuvant situation or neoadjuvant setting, and see if these patients are responding. And we are looking some biomarkers that could be, for example, even liquid biopsy, the waves of this liquid biopsy. As you see here, we are trying to identify this biomarker from the early stage to the advanced disease. How we are doing the search of the biomarkers, this is important. So we can do it two different ways. We can testing in tissue, and that we have advantage of this tissue. The tissue is important. The biopsy, when you go for a biopsy, this biopsy is going to the pathologist. We are doing there the pathological information. So the pathologist is telling to us which kind of tumor is putting the name and the surname of the tumor. And we have from there different also information that we can take. As you see there, they say tumor genotyping, and there are different names. NGS, next generation sequencing, real-time PCR, or FISH are technologies that we are using in pathology, in molecular pathology, to identify these alterations. We are doing now in next generation sequencing that is called or high throughput sequencing. It's very difficult to name, but the important here is that we are using this technology to cover different targets, different biomarkers at once, and have all this information at once. One of the problems of the tissue could be that we have limited quantity of tissue. Depends on the tumor. If we are talking about colorectal cancer or breast cancer, we have a big quantity of tumor, because when they are taking out the tumor, there is a big quantity, and the biopsies are easy to do generally. In lung cancer, the problem is that depends where we are going to take the biopsy. If the tumor is located in an area that is very difficult to arrive with a bronchoscopy or from external biopsy, we can have a small information. So this quantity of tissue that could be very limited is limiting the capacity of these technologies to be performing completely. So pathologists are very creative, and they are trying to do new ways to test that, even with for example, cytologies. We can do a big amount of alterations analysis, but it's better to have better tissue. So another thing that is important when we are taking the biopsy of the tissue, we need to recognize that the tumor is not a ping pong ball. It's an area with different areas of it's a tumor with different areas of evolution that could have clones that are completely different between each other. That's what we call heterogeneity, tumor heterogeneity. So if we are taking a piece of this tumor that is not complete, is not big, or is not adequate of the representation of all the tumor, we can have a partial information of these alterations. So for this reason, the other option is to add liquid biopsy. And I say add and not replace tissue with liquid biopsy. This is very important because the liquid biopsy could be complementary what we are doing in the tissue for information. And there we refer to the DNA, or circulating tumor DNA, that is what we are searching in the blood, generally are piece of fragments of DNA. You saw for sure the DNA that are these helix that are crossing, and they contain different information, fragments of that circulating around the blood, in the bloodstream. We are capturing that and taking the information of the biomarker. It's a very fascinating technology. We have a high concordance with the tissue, so what we see in the tissue, generally we see in the blood. They have the possibility to be repeated over the time, so it's minimally invasive because it's a blood draw, the same that where you're going to take a lab for a normal lab. We are taking the similar tubes, and we are doing this analysis. So we can repeat over the time, and that gives us the opportunity to use as a monitoring. Because if we need to do a biopsy, tissue biopsy, every time that we want to capture information, it's very invasive, will not be representative. The tissue is a problem. And obviously there are costs, and not for not speaking about the discomfort that is very important for the patients. So this kind of liquid biopsy, we call, is possible to capture this heterogeneity that is around in the tumor. There are patients that are not cheaters. That's one of the things. And here we have two exceptions to say. One is that the patient is a truly non-cheater, that he's not really releasing in the bloodstream the DNA. And that could be for different things, could be for the kind of the tumor, the spread of the tumor, the vascularization of the tumor, so where we have the opportunity to go there or not in the bloodstream. But the other possibility could be that the technology is not completely informative. So we are not having a liquid biopsy that is informative. Sorry, you want to ask something? And
I do. No, I probably could spend an hour on those two slides, just with questions and clarifications. Okay. So first off, let me see if I'm following along. Yeah. Okay. And make sure that we're tracking. Okay. So earlier you're talking about how these biomarkers are different than what I've inherited from like my parents. Okay. Because that would be the germline, right? And so like because that's where we started, right? So we're talking about the somatic part, which is within the actual cancer tumors. Is that right? So so this is just within the cancer tumor. This isn't.
Yeah, exactly. That mutation, somatic mutations that are occurring only in the tumor of the is not germline mutations that are the one that we are looking for different risk of cancer. For example, BRCA1, that are important mutations. And for sure, you see several years ago was the case of Angelina Jolie that was carrying this, and I think she was a very good example. She was very, I would say, very kind to offer this information because the people was arriving to get this information out, and is very important. But that's our germline mutations that they speak about predisposition.
Okay. So that's a separate thing. So
Yeah.
first, starting there. Okay, so the biomarkers are separate than what we've inherited. Okay, so we've got that part. And then when we're talking about, you were showing like the IHC and the ALK and the KRAS and whatever with the NGS testing and these sorts of things. You just kind of like clarify how some of the tests identify some of the biomarkers and other the tests don't. So for example, I understand like FISH is different than okay.
So the FISH, for example, is a technology that we are using is in specifically for or the real time, for example, PCR, are technologies that are very sensitive, but we are using for a specific biomarker. For example, FISH we are using for ALK translocation. Or, for example, digital PCR, I can have a rapid test for a BRAF mutation or KRAS mutation. So these kind of technologies doesn't allow us to have important information of a panel, so different alterations together. That is happening with the next generation sequencing. Why is important to have all this information together? Obviously, we want to focus in the alteration that is drug-able. So if I have a technology that is able to give me this alteration alone, good for her. So we are going there. If we have the FISH for ALK, we can treat the patients. But it's important also to know, because we know that several co-mutations we called, and just can impact in the behavior of the disease, just to have an idea. I use the example of a bus. If you have a bus with kids going to the school and you have a driver and these kids are making a lot of noise, can impact in some way how the driver is conducting. And that could happen, for example, if I have an EGFR mutation and I have some companion mutations or co-mutations that are, for example, TP53, that is a very common mutation. 60% of the cancer could have that. Or I have a RB1, that is another kind of mutation that is speaking about a possibility of more aggressive transformation. These kind of commutations can tell me, not that the drug is not responding, but that I need to be very careful that these patients could have a reduction in the time to response. So these kind of commutations are very important because they can impact in what we call progression-free survival, or even in the way that the disease is evolving. So for the reason we are using that, and we are looking very carefully at this information. And then I use another explanation for patients to say, what is the difference between liquid and tissue? And I say, you know, when I was a kid, I remember that my mom was doing these kind of cakes that they call marble cake, that you put different flavors, no? And if I give you a piece of this cake only of the chocolate portion, and I don't show you the cake, you will say that 100% of this cake is chocolate. But if I show you the milk before we go to the oven, you will see that there are other flavors. That is what the liquid biopsy is able to do. So the liquid biopsy is complementing the picture that we have of the biomarkers.
Okay, and so let me ask this question that somebody did post. And it's an excellent question. Does the liquid biopsy need to be done at the same time as a tumor sample is taken?
Yeah, that is the recommendation. We did actually in 2018 and in 2021, we performed the liquid biopsy guidelines from the ISLC for lung cancer, for advanced lung cancer. And we say, in case that you have in case that you have a tumor, there are three possibilities. Or we can go for a sequential approach, that is doing first the tissue, and then in case that we don't have tissue, we go for liquid. The other ones was, I don't have the tissue because it's very difficult to get, I can do the liquid. So I mean, I have the tissue, but I don't have the quantity necessary to do this alterations analysis. I can go for a liquid biopsy to get this information that we call plasma first, because it's the first option that we have. But there is the middle that for me is the most important, that is the complementary approach, doing tissue and liquid biopsy. And why is important that is because we not only have this marble cake picture of all together, but also we have the baseline to understand if this patient is a sheather or non-sheather, if we have a liquid biopsy informative, and also we can monitoring later on the patient response. And this is very important because nowadays we are trying to not only see the driver, we want to monitor the response and identify mechanisms of resistance later on. And I will show you some examples.
Can you clarify how I know if my tumor is a shedder or not? Is it shedding like a dog sheds?
It's a quantity of DNA that is going to the stream. And that could happen, for example, for the histology of the tumor. There are differences between adenocarcinoma or squamous. There are differences between if a tumor has more visceral involvement or not, if they are near to a big vessel. We know nowadays that the non-sheather patients, the truly non-sheathers, are patients that are going better in some way in prognostic, as a prognostic biomarker. And there are some studies that we are publishing now, one that is for MET exon 14 skipping mutation, and giving this idea that when you have liquid biopsy negative, you have a better understanding. But as I say, we need to be very careful that is really non-sheather versus a non-informative liquid biopsy. And now we are using some tools for that. We are doing some mathematical calculations that we call tumor fraction. And with that, we can detect if a liquid biopsy was informative or not.
Okay, and so are there not just some tumors that shed more than others? Is shedding more or less common in different subtypes of cancers?
Theoretically, for example, lung cancer is a tumor that is shedding. We know that. And theoretically, the burden of the tumoral burden, the quantity of disease that the patient could have is related with the quantity of DNA. That is a correlation that is a linear correlation. If you have more tumor circulating, you will have more tumor. If you have more tumor in the body, you will have more circulating DNA outside. For the reason, when we are going to areas of small tumors, or we are going for early detection or what we call minimal residual disease, we need to use technologies that are very, very sensitive to capture that. So we need to change the way of technologies that we are using.
Okay. And how do I know if as a patient? I'm sorry, I told you I could really just keep talking.
No, we are here for that. That's
and I hope when I said I'll interrupt with questions because I have questions.
Absolutely.
How do I know as a patient what testing they did? Because from just basing on what you're saying, no two tests are exactly the same, whether it's the liquid or the NGS or whatever. No two, I get on two different scales at the same doctor's office. I don't weigh the same, right? So I know that two aren't exactly the same. How do I know what's there and what's not? And the percentages, does that matter?
Yeah, if you have, for example, a tissue biopsy that is already telling you that this is a drug-able target, you don't need to have, in 100% of the cases, liquid biopsy. You can have the tissue biopsy, you can start your treatment. What we recommended is to have a complementary approach, but it's not 100% essential to have that. The important that you have this information. Ideally, however, both technologies done at the same time give us an opportunity to have this information complete and have a baseline for monitoring. The technologies both are approved by FDA, so we can use, and there are a majority of the companies are reimbursing that. There are no problem, but generally, if you have a problem, you can discuss with your provider. That is important that you discuss what is available for you, what you can. Important that as a patient, we can always request to the doctors, do I have the biomarker testing done? Because this is very important information, specifically in lung cancer, because we have nowadays drugs that are in first line, so the first option of treatment. So it's important to identify these biomarkers very early.
Okay, well, I mean, I see questions popping up in the chat. We are a very inquisitive group. Okay, so let me
That's good.
Well, Well, no, because we truly do want to learn and understand about this, and I promise. And you probably won't get to all your slides, but I promise it's gonna be fun and interesting. So, Giovanni asks if your tumor was donated to science for further research before it was tested for a biomarker. How common, or is it possible to request that the tissue from the donation be tested for a biomarker?
If your tumor, can you repeat the question? Sorry. If your
Okay,
tumor,
no worries, no worries. That's okay. If I have my tumors donated to science for further research or whatever they do with that, how common or is it possible to have my tissue tested for cancer biomarkers?
so generally, what we are explaining today is more about what you have in clinical practice. So what you have as a patient. Depends of the agreement what you have for when you have this kind of donation for research, which one of the research are involved. That is more part of the research side. I'm talking more about the clinical practice, and what we generally do is this for the patients with the diagnosis. So I don't know specifically for the research.
Okay. Well, and I would imagine it kind of depends on the facility and everything else, because everybody, each different clinic has their own religion of ways of doing things. I mean, it's just kind of the way it is. But it does kind of also bring up, and the question is actually posed about false negatives.
Yeah.
How do we know, and how do we rule that in or rule it out?
Yeah, false negative is a problem because here we are. Majority of the concerns here were the technology that we was using. The technology is evolving very quickly, and we have different alterations that were not detectable before. For example, some of the fusions were very difficult to include in this liquid biopsy analysis. If you are looking, for example, fusions like NTRK or ROS, that they are they have multiple partners, we can say, because a fusion is a part of a gene that is fusion with another, and we need to distinguish the partners that are in this fusion. Sometimes it was difficult to put big amount of these partners and identify all together. That was the example of NTRK. So we need technology that is increasing the possibility to be more sensitive. For example, hybrid capture, or we are using now RNA sequencing in place of DNA sequencing. So that's where some false negative with the technology at the beginning of this liquid biopsy, or even the technology on tissue biopsy, the technology was very poor in sensitivity. That is a problem that we are having nowadays with early detection, for example, that we have or minimal residual disease, that still we have a high rates of false negative, and we need to be conscious that that is happening until the technology is evolving. In advanced disease, we are very sure what we are seeing with the technology. We need to have more advanced in early disease. We are doing great progress in minimal residual disease, but still it's not 100% sensitive like we would like to have it.
Okay, well, and it does kind of like make me wonder how and at what point a cancer gene is changing, like if you're acquiring a new one or you've got a new resistance or what have you. Do they actually know like the moment that happens? Where does that like fall into the whole?
Yeah, I want to show you one slide, for example, here.
Thank you for being so cooperative.
No, absolutely. I try to put some slides, and you see that it's not a presentation, it's dynamics. I use that as an example. Good. But I think it's important because what you see here is a liquid biopsy, and this is waves that are iconographic representation. Is a figure that is representing this quantity of DNA that we see in the sample that we call variant of allelic fraction. But don't remember that name, is the quantity of DNA that we see in the sample. You see that there are waves, and the waves are allocated in a period of time, in a range of time. So this is what was one of my patients that we published actually several cases like that, because it's nice to see how we can tailor the treatment according of the biomarkers that we are discovering. So this is a patient with EGFR mutation, 52 years old, that this started with a stage 4 lung cancer. Also she had a pleural effusion positive, was very symptomatic. And we did there the analysis We started with one drug that is called osimertinib because she have this mutation that is called, I don't know if you see my cursor, but it's called EGFR exon 19 deletion that is there. But she have, as I said before, the BAS and the KITs. She have some KITs that were there, like BRAF amplification, EGFR amplification, that could be KITs that are behaving badly. We will say passenger mutations or co-mutations that are impacting in the driver. And for the reason we saw that this patient could have a good response. Actually, she have a good response, a cranial complete response in the brain metastases. But then she have a period of time that was short in the response. And we see that she have some acquired and resistant mutations. So we are seeing over the time that the tumor tried to escape in some way to the control that we are having. And that could be happening in different ways. Could be in the same gene. We can have different alterations that are, we call on target because we are still on the target. Could be changing the target to another target. Generally could be, for example, some alterations that are not conventional there that we can treat. Or could be in a transformation. In some cases, the histology, the kind of the tumor, could be transformed. And in this case, we treat, and I don't go for the details here, but we was doing different interventions. She was having a complete response, relapse of the disease. We was doing treatment, chemotherapy. What the message of this slide is, first of all, we can have a tailored treatment according to different biomarkers. And the second one is that this is a dynamic process. So this is the acquired resistance is a dynamic process that we have different mechanisms of resistance. It's a clonal evolution. And this tracking this clonal evolution is the most important or crucial time to really impacting the treatment of these patients. If you see, for example, here in the C of this graphic, we started with a tumor that is responding to a drug. We are giving one of the different drugs, and you see different colors that represent the different clones of the disease that could rise or insert in some moment of the disease that they are escaping to the drug mechanism. I don't know if it was clear, more or less, the explanation.
Well, okay, if you could go back one slide, I have a question.
Yeah.
Okay. All right, so I'm looking at this, and it's July of 2018, and I see the EGFR up there at the top, and I also see like BRAF amplification, and I see these other things with like an EGFR amplification, okay? And is it because it's 41%, that's what becomes the bus driver? And then these other things like the BRAF amplification is one of the little unruly kids in the back of the bus? Is that how that works? Yeah. And is it based on that percentages?
Yeah, there are some mutations that are not really impacting, that are what we call genomic noise. So they are not really impacting in that, but there are some mutations that we know, or alterations that we know that could be playing an important role in the behavior of the disease and in the response to the drugs in some way. Specifically prognostic more than predictive of the treatment. Some mutations are truncal. For example, I saw one of the change there, the question that say if the KRAS is changing over the time. So some mutations are truncal like KRAS and will be there. Could be possible that you have different mechanisms of resistance in KRAS, but it's different than mutations that are disappearing and appearing, that they are not really drug-able targets. I don't know if I explained properly this part.
Okay, so it's not actionable.
There are some mutations that are not actionable.
Okay, all right. So like what we've run into before, and we've had Fernando Scalitas from Anderson on, and we've talked a lot about STK11 and the KEAP1 and some of those other little unruly troublemakers in the back of the bus, right?
Exactly.
And we see a lot of them, along with like TP53 and what have you. Okay, and so those are, they're obviously, each person's different. I mean, that's the beauty of the fingerprint of the DNA and the RNA, and also what makes it complicated when it comes to the cancer. But I just kind of like wanted to drill down. I understood it. I think it was clear what it was and how it can kind of transition over the course. But let me check here specifically, see if there's a better, if somebody's got like posted a question specifically to that. I think that kind of like goes to Julie's question about could you actually have more other oncogenes in addition to like a KRAS G12D? So you're kind of saying there's probably one driver of the bus.
Yeah.
Okay, is that right? And then there might be like two primary tumors potentially, so two potential buses and
Yeah.
different kids.
Yeah, so we can have, in some cases, very rare cases, we can have multiple alterations or two alterations together. That is not really a common scenario. And in that cases, we don't have a book to say, I will go to target this or I will go to target the other. So we need to use also the biology to understand better that. We see if there is a possibility to have drugs that are combining or drugs that are covering both mechanisms, for example, in EGFR and MET, in the case of amivantamab. So there are some opportunities. And for the reason, these kind of scenarios are a little bit difficult to treat, but fortunately, it's not something that is happening every day. Some mutations are exclusively mutual, not together. So we know that they are not together at the same time. And that's the case of KRAS, for example, generally is not in other companion with EGFR or other these alterations. So that is clear, and that these kind of truncal mutations are very are alone in this process, and we can target it specifically.
Okay, all right, and then I'm going to hit these questions because it's not just me that has them. Okay, so if the NGS is done with the tumor and it has no match for immunotherapy drugs, well, I'm just going to read the question. What is the likelihood of getting a different result with a liquid biopsy? We were told the NGS gives more accurate results than a liquid biopsy.
So in case that we don't have any biomarkers seen in anything, we know that we have still different options for treatment in lung cancer. We can go for chemotherapy and immunotherapy. It depends on the markers. We are looking also for biomarkers. That is another kind of biomarkers, not genomics, but that's our proteins. For example, the PD-L1 status is a protein, and we are looking for this in the expression levels. We are not doing with the technology of next generation sequencing, we are doing with immunohistochemistry. So we are looking the expression of that in a normal slide. And this is an imperfect biomarker, but it's the one that we are using for immunotherapy. I say it's imperfect because we have heterogeneity that is inside the tumor and heterogeneity that is inside the patient, because if the patient have different site of disease, could be completely different also the PD-L1. But we are using that to treat the patients on treatments. We can use also in liquid biopsy, we can also use not still standard of care, but we are looking in liquid biopsy the dynamics of the DNA. Obviously, we can check the genomic alterations, and for example, what Dr. Skulidis was speaking last time with you about the STK11, KIAV1, ARIAD. These kind of mutations are also correlated with the response of immunotherapy, and we can do also in liquid biopsy that. But what we are searching here is this, the dynamics of the DNA over the treatment. If the patient is responding to the treatment, we will see that there is a possibility to have a clearance of the DNA or a persistence. This is still in experimental part. We are not using that in clinical practice, but we saw several data coming on that, and there are some trials like this that was published by Dr. Ananosto in Hopkins, and we are working in this protocol that is trying to incorporate another name that is escalating or de-escalating clinical trial design. So we are adding or taking out some drugs according to the ctDNA. And that is something that is kind of a window in the future, what we will see in the future. But this is where the trend is going, to try to find biomarkers that give us the opportunity not only to distinguish which kind of tumor is, which kind of treatment I can give, but also how I can impact the treatment using this liquid biopsy to add more treatment or take out treatment from the plan that I have for the patient.
Okay, so what I heard you say is that for liquid biopsy, it's not the best way to, it's not there yet as far as monitoring how well or how responsive you are to what's going on with your current treatment. Am I
That is for immunotherapy, specifically for immunotherapy.
It's for immunotherapy,
For
but there
immunotherapy.
are other ones where you can be monitoring it
For
through.
example, and that is the example that we gave before on EGFR, if we have a good, there is a good correlation between this clearance, what we see here, the disappearance of the ctDNA, in this ctDNA kinetics, in these kinetics that I showed in the first slide with the waves. And we can see there that the clearance complete of one mutation is correlated with the impact in the survival outcomes that we are searching, progression-free survival, overall survival, and that is related very well with the response to the treatment.
Okay, so if you're on a targeted therapy, are there some treatments that you should be getting these liquid biopsies for, but in addition to the scan, say?
This is something that is not in the practice, in all the practice, but it's something that we can do. And actually, several companies are offering kind of combos. We can say that they are doing what they call response in some ways, or they have another names, but they are offering the opportunity to test these different time points during the disease to have a better correlation, not only with the images that we have with the CT scan. Actually, there are a lot of, if we are looking what will be coming in the future, we are also trying to use the RECIST criteria. The RECIST criteria is what we are using for assessment of the disease, and is the dimension of the tumor that we can do, for example, in a CT scan. We are trying to integrate now this with the liquid biopsy results, with this molecular response that we call. And in the future, these efforts will lead to, we will integrate the images with the liquid biopsy to try to understand better the patients that are responding or not. Some patients could have a persistence of disease, for example, but and that was the same when we was incorporating the PET scan, that the dimension of the tumor cannot change, but the activity of the tumor was changing. Here could be similar. We can have a better response in the molecular part, but we don't see still a big reduction of the tumor. So that kind of things are the future. And actually, the next step is to stage in the patients, also incorporating not only the dimension of the tumor, the nodules, and the metastasis, but also the B, what we call TNM-B, so that is for blood, and see in some early stage if this blood is circulating, the DNA is already circulating, and we can capture this information to staging better the patients. So all this is in the future still, but is where we are going and how we can incorporate this liquid biopsy not only in the advanced disease, but also in the early.
It's very exciting for the future. In the meantime, though, if like say, like it's one of the questions that was posted, is like if somebody's currently, say, stable and they're on a targeted therapy, is there some way they can get information about how they could, or just ask their doctor to get a liquid biopsy?
Yeah, exactly. So depends of the practice of the doctors, but generally, if you have a progression in the images, we can, and you have a liquid biopsy before, we can have a liquid biopsy actually again to see if we have some mechanism of resistance, because we can detect that and we can target the disease. And you saw in the case of this patient that I showed before, and I have it back here, that we was detecting mechanism of resistance during this liquid biopsy. And in this period of 3 years or more, a patient with the stage 4, we was able to tailor the treatment using this tool that is liquid biopsy.
It's really getting down to truly personalized medicine, isn't it? I mean, it's
Absolutely.
pretty exciting.
It is. It's really fascinating how this technology, from one side, we can detect, we can monitor, we can also anticipate results. But from the other side, with the pharmaceutical engineering, we was able to arrive to these mutations. That is, for me, is fascinating. How we can arrive to specific alterations with the drugs.
Is there any of the like microbiome that's being taken into consideration anywhere in this?
Yeah, microbiome is another biomarker. I didn't touch in that because it's a little bit more experimental still. We don't have that in the clinical practice, but it's a truly good information that we can get there. Seems to be even in the several of studies that there are correlations for the way of the drugs are acting, the way of the disease is behaving, and how the microbiome, so the intestinal flora, for example, is acting. So there are some studies that now they are looking and they identify some specific microbiome components like Akkermansia that could be, for example, a good prognostic factor to have, or a good flora to have in our bowel compared with others. So, and there we can entrance in the kind of food and the kind of components that we need to incorporate in our diet as well. But that is another topic that is a broad topic, and could be a nice topic for a next discussion, and I can suggest somebody for that.
Okay, yes, all right. So we'll put that on pause for the future at some point. But in order to track the evolution of these tumors, is that something that we should just kind of be doing on an ongoing basis? Do you have to be part of a trial to do that, or is that something that I can do at most clinics?
There are several trials that are trying to identify these and monitoring these patients. In the clinical practice, for what we have nowadays is if you have a targeted therapies, you are on a treatment, and there is a moving of the disease, growing of the disease, you are not responding, important message, request to be tested, because this is important that we identify the reason why this disease is not responding or is escaping to the control of the drug. And that could be, as I say, alteration that is on the same target, an alteration that is completely different, or a transformation even of the tumor. So these kind of scenarios need to be tested with tissue, with liquid, or with both at that kind. And for example, in the case of the transformation there, we will need the tissue to demonstrate that.
You're in an exciting area of research. This is pretty hot stuff.
Absolutely. And I invite you guys, if somebody wants to participate in our Congress, we have the Liquid Biopsy Society that I put here. I will put the slides, and we have this is in Orlando this year. We will have.
Didn't seem to get an invitation, Christian. I'm not sure why.
We are still in the program, but this is a save the date. Because it's interesting, we have open slots also for advocacy groups, and if you are interested on that, we have opportunities also for education in the society and participate in our events. That is important to have the voice of the patient, as I said before. Very, very important.
Well, and you're really very receptive to it as well. And so, like, you really are. And when I said like old world charm, I mean, I really mean it. Don't worry, I'm not done with you yet. So just don't go thinking I'm wrapping stuff up here. So, okay, because we still have more questions, and you made it through half your slides here. Okay, so I'm just going to ask Rose's question. Is there a specific test to find out your HLA type for potential T-cell treatment?
Yeah, this is another kind of biomarkers, and we can do a specifically test for that. It's not used that in lung cancer at the moment. We have this information that we are accumulating to see if these immunotherapies are responding or not. Seems to be also a biomarker there, but is in clinical practice in lung cancer we are not still using. But there are technologies that we can apply for that as well.
Yeah, we had Dr. Greenberg from Fred Hutch talking a lot about the HLA thing. And I think, I don't know if they're still doing it or not, but it was like a spit test. And in order to see it, because there was a specific clinical trial that there were, people were being able to qualify for. And so there's that. Okay, I'm just going to.
Yeah, and several, that's important. No, several trials are testing different technologies. We have a lot of going on the new technologies. We have also some components that are, for example, biomarkers in HER2, for example, the HER2 overexpression. We have different behavior for biomarkers that could be in breast cancer, in gastric cancer, and in lung cancer. So there are some companies that are working in companion diagnostic. What means that? There are tests that are specifically directed to this target. and is a companion of the diagnostic associated to a specific drug. So it's not one blanket test for everyone in some cases, and specifically if you're going to clinical trials, you will see that the doctors are offering also in the clinical trial testings that are not the normal ones in some cases, because we are looking at specific tests to validate a specific test for different alterations as well.
Yeah, my hope is that when the companion diagnostics are approved along with the drugs, that one of the requirements will become that the patient gets a copy of the report of their biomarkers, because until we actually see, when we see a copy of the report, we have no idea what actually we've been tested for at all. And there's no other checks and balances, I guess.
No, you are touching on a very crucial point. And my suggestion, and I say always to my patients, I try to give a copy of the report because it's important. This is your information. You need to keep a copy. If you are going to another doctor or if you ask for a second opinion, it's a crucial information. And even if you are testing, now we are testing in early stages, and if the patient have a recurrence of the disease later on, and you maybe are going to, or you are living in another city where that was happened before, this information is crucial. It needs to be part of your record. Actually, this is one of the big things, how we are reporting this information. And one thing is to have all the necessary information to have a comprehensive vision of the visualization of the drug that is necessary, the target, how they have the characteristics, but also how we are integrating that in the medical record. Some of the problems that we have nowadays that when we have external vendors or that are not in-house technology are not integrated sometimes in the medical records and are coming as a PDF. So we need to be conscious about that, and it's important, as I say, conserve a copy, ask for a copy of your results, and it's important to keep in your. Nowadays we have my chart and generally are there, but it's also important to identify if they are there. If it's not, a paper is always useful.
Well, and it also helps too, if I'm talking from this patient to that patient, right? If I know what things we have in common, okay, I'm comparing apples to apples, not apples to oranges, right? An EGFR patient on a different TKI is going to have a different situation than an ALK or a KRAS G12C patient. So
Absolutely.
it helps that as well.
Absolutely.
So, okay, but all right, and then here's the question: is the VAF typically the same in tissue and blood biopsy?
Are calculated different, but what we are referring here in the BAF, so the way of calculation is different, but what we are using more this technology, the name or the definition is more for ctDNA, because we can calculate these dynamics over the ctDNA. The BAF is an information that is the other characteristics are more for the pathologist, but what we get in the liquid biopsy is what we can apply in these kinetics that you saw in the graphics.
So does it matter if it's the same or the different?
Sorry, second.
So does it matter if the numbers are the same or they're different?
Different, because this depends on the samples. It depends on specifically of the sample.
Okay, so what I'm hearing you say is like back to your mom's marble cake. If we're taking a different sample from a different part of the cake, we might have a different percentage of chocolate versus vanilla.
I will focus more in the liquid biopsy. So let's say if I take the blood of the blood and I see the BAF generally is similar because it's related with the DNA that is in circulation in the sample. Gotcha. And another common misinterpretation that could happen is that they say, for example, if I have an EGFR mutation and it's only 0.01% of the BAF, do I need to have a higher or a lower to be able to be treated? It's regardless. That is, if you have a presence of an alteration and the BAF is even very minimal, you can respond to the treatment. So
if it's there, it's there.
It's there, it's there.
Okay. I have one more question, then we'll get back to
the
slides. Okay. Would you class neoantigen cancer vaccine as immunotherapy? And would you recommend a liquid biopsy in addition to a scan for patients? Okay, this is a long question. In addition to a scan for patients, NED after multiple recurrences of colon, liver, lungs with KRAS G12D.
I will try to read by myself.
Okay, yeah, you do that. Okay.
No, I don't have this question here, but maybe you receive
Okay,
it.
so let me read it slower, okay, because I was like, I broke it up too much. I said it weird. Would you class neoantigen cancer vaccines as immunotherapy? And would you recommend, because it was a two-part question, and would you recommend a liquid biopsy in addition to a scan for patients that are NED? Let's do that part first.
So the first part is for the neoantigens. There are technologies that are doing that. It's not the standard of care. It's related to a specific drugs or a specific drugs that are in research still, because we don't have still the vaccines specifically designed for every patient as a clinical practice. But there are some trials that they are doing that, and they can have this information. The second part is the question was the CT scan and the liquid biopsy at the same time. That is something that could is not the standard of care practice. What I generally do in my patients that are in targeted therapies, I like to see the response of this clearance after some weeks, is generally in concordance with the first CT scans, to see if there is a decrease of the ctDNA. But it's not, as I say, it's not an use practice. There are several vendors that are offering this opportunity, so it's doable. It's not 100% still in the guidelines of clinical practice.
Okay, but if you're on a neoantigen cancer vaccine, that's presumably part of a clinical trial, and so it's going to be whatever the clinical trial is going to be, because it's just not like a standard sort of.
Exactly, depends on the clinical trials, and generally the clinical trials are looking, if they are looking for these biomarkers, they will do different tests to have this information that as a part of the analysis or the exploratory analysis for the future.
Okay, all right. One more question in here, but these aren't even mine. Okay.
I try to do my best. Some of the questions are very clever, and it's difficult to.
No, you're doing a fabulous job. You're doing a fabulous job. That one I just kind of tripped over the way I said it. Okay, it says I'm seeing a return to chemoplatinum. Is that okay? I don't understand the question. I see a return to chemoplatinum in one case. Is that a seen practice? I think standard of care practice is what the question really is.
Yeah. So chemotherapy is always a backbone in cancer, in lung cancer. So we can, when we don't have other options after the target, that be an option. And we have, and actually several patients are responding very well. So is part of that. We can discuss immunotherapy or not. We know that the targets in immunotherapy, specifically the canonical targets, EGFR, ROS, and the others, are not really responding to immunotherapy, but chemotherapy is an option. And in the United States, we are very lucky that we have an opportunity to have access to different drugs. And this is a blessing, I will say, because FDA was really working very hard to have these approvals in time. But it's not the same scenario that is happening around the world. So around the world, we don't have all the generations of the drugs are approved or reimbursed. So we need to be also conscious that in several places we are still using chemotherapy as an option, and in our patients we can use it as well.
Well, it even depends what year you were diagnosed.
Exactly.
I was diagnosed 8 years ago, and that's what I had. That's pretty much all there was, really. I mean,
as I say, KRAS was one of the last to be targeted.
Yeah.
And chemotherapy was working, and it's still an option.
Well, we have a long ways to go, because there's still so many other KRAS, because I mean, I'm not a G12C, I'm G12D, and so now there's so much more happening with that. I'm going to let you get back to your slides though, because that's what really starts tricking the questions. But you see, one slide just leads into 50 questions because we're just hungry for info.
I can back.
You're a fabulous professor, Christian. Thank you.
Thank you. So I come back here to show some examples. So this is what we was discussing more or less. We discussed about HLA. We discussed about some much more is including the microbiome that we was discussing. This has to say what you was telling right now. I'm a KRAS G12D, and is different. So we have different alterations that we can target. And I was talking about the fusions, and this is the example that we have with the NTRK fusion, that are 3 different fusions, but this is important that the testing is not related to one tumor or other. So we are trying to test different patients because, as you can see in these images, kids or even adults will have this alteration in their tumor. So it's important that we are testing, and that is the message that we can say. Testing is the most crucial point in the diagnosis, because we can have here important information that can change radically the way that we are treating the patients. And that is more or less the slide that I have. And then another thing, I didn't include a lot because I saw that we was stopping in every slide, and it's good. We can do in the liquid biopsy, for example, during the immunotherapy, prior the treatment, or over the course of the treatment. And prior of the treatment, in some tumors, tumor mutational burden, TMB is one of the biomarkers. In lung cancer, doesn't seem to be 100% positive. We have contradictory results. I think that if we want to have a kind of Lazarus effect of the TMB, we need to be more responsible because probably in some biomarkers, we are really needed in immunotherapy. And we are trying to do different approach, different panels to testing, different cutoff. So if we need to be a little bit more responsible, maybe in how we are also doing this discovery of some biomarkers. And then we was discussing about this the genomic alterations and the mutations or the dynamics as well that we can check. And you see there, it's not only related to lung cancer, it's also for different tumor types.
Well, and I didn't know the difference between a solid tumor, or if there was, had no idea that there was such a thing as a solid tumor until I got diagnosed with a cancer, right? Now it seems like we're almost going back to, like, because this is in the blood. And so there's still a hematological component, even if it's a solid tumor, because it's how it seems to be spreading.
Yeah, and actually we are having also, we discussed today, because it's my area, solid tumors, but there are also several biomarkers for hematological disease. They are using similar technologies, liquid biopsy as well. So there are it's a great tool, I think, that we have in different tumors, and the possibility to personalize, as we say, the treatments is fantastic.
Okay, what do you think the most important component of everything we've talked about today is?
I think the final message is test, get tested or ask for a test. And that is happening. Several patients, are coming to, I heard about this drug, or I have about this drug, because they see a lot of in the television advertisement and so on. We need to also create a lot of education. And thanks for the opportunity, because I think it's very important that we discuss this. As a patient, also, you are aware about this advance in the technology that can change your treatment, can change your disease, how it's responding, and it's important to ask and discuss with your doctors. If your doctor doesn't know the answer, continue to ask. So nobody is offended because you are asking. This is the most important.
Oh, that's not true. The good ones aren't offended when we ask.
No, I'm open always when my patients say, I would like to have a second opinion or something. I say, let me know who you want to go, or if you want to have a second opinion, because I want you go to somebody who can teach me also something, and it's important that we have communication. So we are here. Always I say to my fellows, I try to be answering the question as you are in the other part of the chair. If I am in that side of the chair, what I would like to be hearing from my doctor, what is the answer, what I want to be supported. So that's the most important part.
Let's talk about that second opinion thing real quick, if we could, okay? Mm-hmm. Because it's scary as a patient, okay? I'm telling you, I know, because I was too afraid to go get a second opinion, okay? Just because you see me running around now doesn't mean that I did that then, okay? And so it was scary. And now, having had the opportunity to be at some of these conferences, and I see you guys up there, and I don't want to say you're arguing, but I mean, you're having solid intellectual debates and conversations about opportunities and threats and different approaches and the strategy in order to really make a difference for a patient. And so that second opinion, when you're saying it's welcome, I mean, you actually are truly welcoming it. You want to have that conversation and you're encouraging it. And so, as scary as it is as a patient, really it is. It's okay to ask for the question, ask for the question. It's okay to push out for it because you guys, I mean, are really so receptive to having that happen. And when I finally did get get my feet underneath me so I could do it, it made all the difference. It didn't change any treatment for me, but it made all the difference in my confidence. It made all the difference as far as being able to feel more connected and like I really was on more solid ground.
I think this is crucial. So we are not talking here about the doctor. We are not talking about your professional ego. We are not talking about that we are putting in question marks about your judgment as a doctor because a patient is requesting you to have a second opinion. If I'm in that side, I will also like to have this information. What is also important that we are not losing time in multiple second opinions. And that is also interesting because it's important to remark because some patients are going to different doctors different times and the time is consuming and we have passing time that we can start with a treatment. So important that you select if you have second opinion. There are advocacy groups that they know who are the experts in the area. And you can also contact the advocacy groups and say, like in your case, KRAS Kickers, you have a good knowledge which one are the people that is working in different areas. And it's an enrichment to have the opinion of a leader, key opinion leader for a doctor in our practice. And we can learn that we are here for learn and continue to grow. That's the idea. And
Well,
help
and
people.
it's happening so rapidly.
Absolutely.
I mean, so rapidly that it's tough to even it's I don't want to say it's tough to keep up for everybody, but I mean it is a sense of accountability. And so one of the big takeaways I'm always giving out to people, and I'm hearing you say it, is getting that second opinion, having those biomarkers done, and then feeling like knowing that having a copy of your report. You know, as much as we keep trying to put everything on our computers, like a piece of paper in your hand or on your chart so that you know what you've got and you can get, stay informed about it and then retest at progression.
Exactly. That's our the elevator pitch message.
Well, but it's super important. And, and organizationally as like patients and communities and whatever, I'm a firm believer in fact, I'm going to share my screen, which is something I'm normally not doing. So I'm not even that.
See you perfectly.
Huh? I was going to share my screen. I have a, what do you call it? Of all the different groups because it's just, here it is. There you go. Share. There we go.
Thank you. I see here people saying thank you and I really appreciate it.
Oh, good. Well, okay, so I mean, it's very important, I think, for patients to get connected with other groups that are what they have. And I'm not against any single group at all. I mean, we're all in this together in some way because once you have cancer, you're part of an extended family of some sort. And you just don't drink all the water from just one well, get information from more than one group, get connected. If you're KRAS, join us. If you have lung cancer, pancreatic cancer, I mean, the PanCan folks just gave us a lovely shout out, in their newsletter. And it's important to know that it's not all one place, but it's not just where it lands. But if anybody has any last questions, go ahead and pop them in the chat. But otherwise, I'm going. Whoops.
And you don't know how lucky you are here in the United States to have these different groups. Yeah. In Europe, we are starting to have some of this group, but this is a unique opportunity that you can be in a community. You can be not only sharing different experience, but also sharing knowledge. That this is very important and making strength to go to give this advance and contributing also in fundraising and opportunities to continue to develop research. This is really, really important.
Well, we actually are in across Europe. I've been to Europe a number of times. Actually, I know you went to school in like Milano, and so I've been like there in Torino, and I had to turn down Ravenna again this year. Love Italy. I'll be going to Spain a couple of times for whatever. And a lot of it is being able to connect with folks there. And in our organization, we have people like within, not our organization, what am I talking about? Within the community, within our
Yeah.
KRAS Kickers community. Okay, there are 117 countries, and we use Google Translate. And it's really powerful to see that as some of the drugs are starting to happen and we're getting the information and it's happening here in the States, and then they're more receptive across Europe, but they're getting more fired up. They're getting a little bit more of an American sass, shall we say, to kick their KRAS.
No, thank you. And thank you very much.
But thank you so much for joining me today, Christian. I mean, it was just an absolute pleasure, and truly, you know, such a gentleman and just so well informed, and I appreciate your, you know, your tolerance with asking a million questions. And honestly, if you had one more slide, we probably could go another hour and a half. And so I appreciate your taking your time with us and everything that you do for the community.
Thank you. Thank you very much. And I'm here in Ohio. If you need me, you can contact me. If you never visit Ohio, we have a lovely things here. So,
I've
but
been to Ohio.
we
It's
also in
gorgeous.
Congress.
Well, or you're Orlando.
Exactly.
Right.
Exactly.
Right. Okay, well, it sounds good. Well, thank you again
Thank
so
you.
much. And
Thank you
thank
so
you,
much.
everybody, for joining us. And thank you. If you have questions, hit us up. There will be a replay. I'm really slow on getting it on YouTube, but it'll happen, I promise you. So thank you all. And we're going to end it with that. And I'm Terri Conneran with KRAS Kickers. Thanks for joining us today. Bye, Christian. Thank you so
Bye.
much. We
Thank you.
appreciate
Thank
it.
you.